cardiac or non-cardiac symptoms. So the index of suspicion, definitely we have to identify also some pains that may not be related to the heart, and some others that can be cardiac. I understand definitely sometimes it's confusing, especially where according to the patient like understanding of how pain is. So, but in general, like sharp, fleeting, shifting, sticking, all those like yeah can be in the low risk category, and we go forward like stabbing and dull aching and also central pressure, squeezing, gripping, all those can give us like high risk or high probability of ischemic pain. So the initial evaluation, we have to focus on history, including the characteristics and duration of symptoms relative to presentation, and also the associated features like cardiovascular risk factors, assessment, those everything all should be obtained. This is the top causes of chest pain in the emergency department according to age, and we can see that the chest pain can range like between like young aged until like 80 or more than 80 years. But from this, like yeah, most of the time it's non-cardiac chest pain. And we have to, but still, chest pain, we should consider this as an emergency until proved otherwise, because what seemed to be non-cardiac, sometimes it can be cardiac and can be a deceiving symptom, especially as I said before, in some women, they can describe like pain in different other ways, like angina-like symptoms, like shortness of breath, or feeling tired, or so and so. So still, we need some meticulous investigations and assessment of those patients so we can identify those patients at risk. But sure, the patient category between like 18 and 44 years of age, you can see, you can appreciate here that the non-cardiac chest pain or non-specific chest pain is the most common, but painful respiration, abdominal pain, bone and musculoskeletal pain, and anxiety, superficial contusions, all those are considered like even like more common than cardiac pain in those patients. But once we move to the category between 45, 64, and sometimes 64 to 79, you should consider coronary atherosclerosis or ischemia. It can be the second most common cause of chest pain. So we have to be like very careful and giving like some more attention for those patients above 45 years of age. Also, the pain, we have to identify the character of the pain, because sometimes not all the pain is ischemic, but it can be like other serious issues like pulmonary embolism or aortic dissection. So we have to go through the history and also the character of the pain and the physical examination to identify those patients. So, and this is, as I mentioned, like, yeah, women, they have like a special position in the guidelines because of I will not say the unusual presentation of their chest pain symptoms. So we have to identify women who present with chest pain at risk for underdiagnosis or potential cardiac causes should be always considered. And also in women presenting with chest pain, it's recommended to obtain history that emphasizes accompanying symptoms that are more common in women with acute chronic syndrome. Also, consideration in all patients, especially diabetic patients, we have to, in patients more than 75 years of age, acute chronic syndrome should be considered when accompanying symptoms such as shortness of breath, syncope, or acute delirium are present, or when unexplained fall has occurred, because sometimes it maybe the presentation was a brief or non-sustained VTAC or something because of ischemia, which is definitely can lead to some poor outcome in the future if we don't identify those patients right. here there are some other consideration that we have to take in when like we're dealing with patients with other diversity, like or cultural a different cultural background, especially when like we are seeing patients from other countries and so on, and their description of their chest pain can be a little bit like different from what we have. And especially, I remember when I first came here, as I mentioned before, the expression of stomach pain was uh, always the term that they keep saying, and also gas pain is always the term that the patients mention during the consult. And if I'm not aware of the cultural difference and also the way that they describe the chest pain, definitely this may create confusion and sometimes delay the proper intervention. So here we need to identify, as I'm saying, as I said before, like the different the subtle, or I would say like the minor differences between the chest pain, especially emergency chest pain. So in acute coronary syndrome, we can see patients with diaphoresis, tachycardia, tachypnea, hypotension. Sometimes they present with crackles because of acute heart failure or murmur if there's like something like infralateral posterior myocardial infarction that's affecting the circ and affecting the mitral valve and causing acute regurgitation. Those are symptoms that you can see with acute coronary syndrome. And when we say acute coronary syndrome, we refer to STEMI, non-STEMI, and unstable angina. Pulmonary embolism, the most like common clinical features that we see: tachycardia plus dyspnea in more than 90%. And sometimes it can be associated with pain during respiration due to pleuritic pain or massive infarction pain. Aortic dissection, this is a disease that sometimes is unpredictable. It comes with some syndromes like Marfan syndrome, which is a connective tissue disorder. And also sometimes you see it like in patients with severe uncontrolled hypertension or previously known to have aortic aneurysm. It presents with severe pain. Definitely, once you see a patient with aortic dissection one time, you will never forget him, because they describe severe pain that tearing their back, especially, and it goes like according to where the extension of the dissection is going. So sometimes to the loins if it's affecting the renal arteries, and sometimes to the legs because if it's affecting it's going down to the iliacs and so on. And also it can present with chest pain also if it's like thoracic aortic aneurysm, a ruptured thoracic aortic aneurysm, and can present with syncope if it's going to the carotids or something, or because of the severity of the pain, and the patient can present with vasovagal symptoms. There's also like a non-cardiac or cardiovascular related thing like esophageal rupture or tear. This is present with vomiting, subcutaneous emphysema, pneumothorax in 20% of the patient, and sometimes unilateral decrease or absent breath sounds. There's other non-coronaries like aortic stenosis, which is very like common to see patients with the aortic stenosis and having like chest pains. And for like common features of aortic stenosis: chest pain, shortness of breath, syncope, and sometimes like they present like with kind of strokes and so on, which is something that we have to identify. And also it can be identified on physical examination by hearing like a murmur that is rotating to the carotids or something. Pericarditis, mostly it will be accompanied with fever if it's an acute thing. Sometimes it's post-infection, so may not be presented with fever, but we have to ask also, especially in young patients, about like any flu-like symptoms or viral infection recently and so on, especially if we do the echo and it shows significant pericardial effusion or significant drop in the left ventricular ejection fraction. Also pneumonia, pneumothorax, costochondritis, which is it's very, very common to see, especially in young patients who are exposed to like some temperature changes or some strain on of their like chest muscles and so on. And it's peculiar when they mention that there's like some kind of chest pain that increased with breathing or tenderness over the chest wall or over the external junction with the ribs. Also, one of the common things that can cause the chest pain, and you have to be like aware of that, is the herpes zoster. We saw it many times. Patients presented with chest pain, but he couldn't identify any lesions on the skin. But definitely you have to look at the dermatological like distribution of the nerve and so on, and you can see like yeah something like encircling the patient chest, visible small vesicles, and this also like yeah can be identified and treated in another way. So here, this is the recommendation, what we should be doing and what we should not be doing in case of like, yeah, high risk, low risk, and no risk patients. So if we are not like we couldn't identify non-cardiac cause, so ECG should be performed to any patient, especially in the age category that we mentioned before, about 45, because most likely, especially when you see a patient with like who says that epigastric pain or I feel like nauseous or something, and many physicians they identify them as like gastritis and they treat them with proton pump inhibitors, and the patient like will have some initial relief and then will start the pain start to come back again. So we don't want to miss the chance to do an ECG because it can be a STEMI, and we missed that. So this is one thing. Also, the patient with clinical evidence of acute coronary syndrome and other life-threatening causes of acute chest pain in the office should be transported urgently to emergency department, and the best to be like yeah with an ambulance. This is very, very important because sometimes many physicians they think that okay, this is chest pain. If I can start some medication for this patient, I can and this would relieve that pain, so that's right, and we can postpone or we can do the other investigations or send him to the hospital later if he responds. But this actually, like we saw it many times, that the patient developed like a heart attack, either STEMI or non-STEMI. He's not identified by his initial physician, and he goes very late after worsening the symptoms to the hospital, or sometimes they got a missed myocardial infarction, and they go like later, maybe weeks after, and so on, and after the damage has happened already. So any chest pain, if we can definitely identify the cardiac from non-cardiac, definitely that would be good, but still we need to identify again to do other tests to confirm what we see, because simple ECG can save lives. So this is very important. So once we identify those patients in a clinic setting, so we need to send them to a hospital or an emergency department immediately. This is also like in the setting, the same thing in all patients who present with acute chest pain, regardless of the setting, an ECG should be acquired and reviewed for STEMI within 10 minutes of arrival. This is like when the patient arrives to the emergency department, and also present to the emergency with acute chest pain or suspected acute coronary syndrome. Troponin test should be done. Troponin test, I know that here in Jamaica, most of the hospitals, they do it like, yeah, in a lab setting, but actually many hospitals now, they are adopting the presence of what's called iStat, which is a small portable machine that can do the troponin test immediately. And this will definitely identify those patients who are to rule in or to rule out those are cardiac patients or no? Because if the troponin is positive, especially like in 0 hour and 1 hour and 2 hours, if any result comes back positive, that confirms the acute coronary syndrome. But for patients with acute chest pain and suspected acute coronary syndrome initially evaluated in the office setting, delayed transfer to the emergency department for high sensitive or like regular troponin test and other diagnostic tests, then should be avoided. And this is like class 3, which means like this is harmful if those patients are delayed from going to the hospital. So here, the management of chest pain, as we mentioned, so this is the algorithmic approach of every patient with chest pain. First, the history, physical examination, and then the ECG. Definitely STEMI means like ST elevation, myocardial infarction. We have to follow the STEMI guidelines, which is either like briefly, we should say, the patient who is in a hospital or can be transferred to a hospital with cath lab facility within like 1 to 2 hours, the patient should be transferred immediately without any delay. If it's more than 2 hours, definitely we should like give thrombolytic and then send the patient to a cath lab facility anywhere in the island, as long as we are in the first 12 hours. The best in the 12 hours, we can do it up to 24 hours. Definitely after that, if the patient's still having like symptoms and recurrent chest pain, it would be like a rescue PCI, or he still need to go to the hospital with a cath lab facility. This is very, very important because we lose a lot of patients, and also we lose a lot of muscle, as we can say, and patients present late if they don't like, if they cannot like be treated by algorithm that we mentioned. Diffuse ST elevation that sometimes is present in pericarditis. Pericarditis is another situation. I hope it's sometimes benign, most of the time benign situation that can be treated with NSAID and so on. It goes well, but also you need to identify what's the cause of pericarditis in those patients. ST depression and UT wave inversions, we have to follow the non-ST segment elevation guidelines. It's a little bit different from the STEMI guidelines, but in one sense or another, it is according to identification of the risk of the patient. Very high risk patient needs immediate intervention. High risk patients needs intervention, but not immediate. The intermediate and low risk patients still need some more investigations to be identified, but sooner or later they might need intervention as long as the troponin test is positive. Non-diagnostic or normal ECG. So repeat the ECG if symptoms persistent, and if troponin is positive. So someone can say, like, if the troponin is positive, why we need to repeat the ECG? Because sometimes the STEMI doesn't present as STEMI. It takes some time, and then all of a sudden you can see that there is a dramatic change on the ECG, and you can see a sudden elevation of the ST segment, and this will change the category of the patient from non-STEMI to STEMI, and definitely we have to call for STEMI call, do the STEMI call, and intervene as soon as possible. Also, sometimes when you do a regular ECG, you don't see the changes very clear, and sometimes we need to do a posterior ECG that identify those posterior myocardial infarction. There is a simple like maneuver to do this, is to like to flip the ECG and look at it at the ECG from behind. You can identify like, yeah, the instead of the Qs and ST depression and the V1 and V2, you will see it like as ST elevation and long R in V1 and V2, which you may like the physician suspicious about like posterior myocardial infarction. So it will be treated as STEMI at this point. Definitely also the ECG will identify any kind of new arrhythmias, especially atrial fibrillation, which is the most common. In patients presenting with acute chest pain, chest radiograph to evaluate those potential other cardiac, pulmonary, and thoracic causes. For me, yes, sometimes, especially in patients with with the history of trauma or something, this might identify pneumothorax, pneumonia, and sometimes massive pleural effusion or pericardial effusion. In patients presenting with acute chest pain, definitely serial troponin test is useful to identify abnormal values or rising and falling in pattern that indicative of acute myocardial injury. This is also very important because like in acute coronary syndrome or STEMI patients, we can see a very high uprise and downfall, especially after intervention. This definitely tells that this is myocardial injury. Sometimes we still can see a positive troponin or high level troponin, but it's mildly elevated in patients with heart failure. So the difference here is that in heart failure you will see that the troponin level is a little bit elevated, but it doesn't fluctuate too much. So you'll find it the same the next second day, and after the patient start to improve, it will become a little bit less, but you will not see a very high elevation and sudden drop in the levels of the troponin at this point. In patients presenting with acute chest pain, high sensitivity troponin is the preferred biomarker. I understand definitely that most of us call for the cardiac panel, which is CK, CKMB, troponin, and ESOT and ELT. So those are we use to, but the most important is the troponin because this will show us the diagnosis and also the prognosis later on. In patients with acute myocardial injury, we have to understand as I'm saying, the elevation and decrease in the troponin level, and we have to identify those things because this will identify the myocardial injury at the end. But with the availability of the troponin, creatine kinase, CKMB, and isoform enzymes are not useful for the diagnosis because still they are not so specific, okay, and it can be affected by many other factors. So here we are talking now about testing, what kind of testing that we need to do for those patients. So we have two different categories. Definitely, we have to identify patients with chest pain. Is it acute or it is a stable chronic chest pain? Some people can come to the clinic stating that they have chest pain every now and then, especially when they walk or go upstairs or exert themselves. So this, but not now. So this is not acute chest pain, and the way of dealing with those patients will be totally different from acute chest pain. All right, so definitely asymptomatic. We don't do things routinely in patients with no symptoms at all. In low-risk patients with acute chest pain, we have to identify first which this is non-cardiac pain, so there is no testing. If it's suspected to be having intermediate risk or something, we need to do an ECG and sometimes anatomical or functional test. In high risk and acute coronary syndrome patients, definitely invasive coronary angiogram would be needed. In patients with stable chest pain, it will be either to do a nuclear test, stress test, either stress ECG or stress echo. And sometimes we do the CAC, which is the calcium score, or sometimes we can do, if the patient has low to intermediate risk, we can do what's called the coronary CT angiogram. So how to choose the right pathway with patient for the patient with like to identify like how to go with the guidelines in this situation. So as I said before, acute chest pain, if no, so we will evaluate the patient according to the stable chest pain section, as we mentioned before. If yes, definitely history and physical examination, ECG immediately, potential cardiac cause. If no, so evaluate for non-cardiac causes, other causes in lungs or the esophagus or whatever. But if the it's a potential cardiac cause like STEMI, yes, so we activate the STEMI call. If no, we evaluate the based of the suspected etiology in those patients. Still acute coronary syndrome, we have to like confirm or rule out. Acute chronic aortic syndrome also, this is very, very important to identify those patients, because sometimes some people are confused, like, yeah, we do the ECG, especially in type 1 and type 2, like aortic dissection. Sometimes it affects the origin of the right coronary artery, and we can see a stimulation in the inferior leads. So we assume that this is a STEMI call. We do the angiogram, and sometimes we don't see any lesions in the right artery, but if we are lucky enough, we can see that we can, like, when we inject, we can see the dissection flap. But because of the injection, it can be very serious, because we can increase the dissection flap, and this can be like even lethal. Also, pulmonary embolism, definitely, the presentation of patients, especially in young patients after like long trip or surgery or something, this can give us a clue that this might be a pulmonary embolism, especially if there's no significant changes on his ECG and the troponin is negative. We can do the D-dimer. D-dimer is a good negative, but sometimes it's like non-specific. But the higher the D-dimer, it can tell us like, this is more likely to be pulmonary embolism, plus identifying the patient by Wills score. Acute myocarditis, it will be like, history of viral illness or sudden shortness of breath and so on. And this actually, it can be identified better with an echocardiogram. And valvular heart disease also, the sudden acute valvular problems definitely can cause acute chest pains. And we have to identify those patients as well, and by doing an echocardiogram. Here, after doing the ECG, obvious non-cardiac cause, so this is no test is required. Obvious non-ischemic cardiac cause, we identify the other cardiac testing as needed. Impossible acute coronary syndrome, we obtain the troponin, we do the risk assessment, and to stratify low risk, no further testing, especially if the troponin is negative. Intermediate and high risk patients, definitely we do the other diagnostic testing, especially echocardiogram and or invasive coronary angiogram. But we don't want things to be delayed, especially in STEMI patients. So we go straight forward. If we can do the echocardiogram in the same sitting while we're doing the angiogram, or like, on the way to the cath lab, definitely that would be good, because sometimes we can identify some other serious things like myocardial rupture or acute valvular regurgitation. Here, this is also like, sometimes we ask ourselves, like, if I do an anatomical like test, like angiogram, and the test is normal, what is the validity or the time that we can say that this patient stay, like, if I find it normal, how long it can be abnormal. So with like, after like, research and so on, the normal in normal coronary angiogram, it's up to 2 years, or CCTA, which is the coronary CT angiogram. If there's no stenosis or plaques, it's up to 2 years. In stress testing, normal stress test can be adequate for 1 year. And evaluation of patient with the stable chest pain. Here, those are the probability according to the age. As we mentioned, the younger the age, the probability of having like acute coronary syndrome or not acute coronary chest pain, like cardiac chest pain, is less probable, and definitely by going uh, with age upward, definitely the risk start to become more. Here, there's a very valuable test. It's not widely available, but it is like it still can be done, especially that it doesn't need like a high slice rate CT scan. It's called the CAC, or calcium coronary artery calcium score. This is also, it can be a very good predictor for those patients, especially above 40 years of age. If the CAC score is between 1 and 99, it is like low risk. Between 100 and 999, this will be intermediate risk, and above 1,000, definitely it will be high risk. So those are like giving us the pre-test probability of those patients having angina pain due to cardiac reasons or not. Here, this is how to identify the pathway of every patient. As we mentioned before, in the low-risk patients, there's no testing is recommended, but we still can do like some exercise test, ECG or CAC score, just to make sure that the patient doesn't have a hidden risk, and we don't like see. In intermediate to high risk, one of the good tools that we can do if we don't want the invasive maneuver, but unfortunately is not widely available here in Jamaica, is the coronary CT angiogram. And if it's not conclusive, sometimes it is not a highly accurate test sometimes, especially if there's artifact or the patient is breathing heavily. So it can be sometimes inconclusive, and we at this point, and we still having doubts about if the patient has cardiac chest pain or not. So we can do stress testing. If there's no with the CT, the multi-slice CT or the CCTA, if there's no cardiac stenosis, coronary stenosis, so we consider maybe, and we can see that this is still intermediate risk, so we can consider INOCA, which is ischemia with no obstructive coronary arteries. So, and this will be treated most of the time as ischemic heart disease, but definitely with no further intervention. If we can see like non-obstructive coronary heart disease less than 50%, or obstructive coronary heart disease more than 50%, we can do what's called FFR CT. It's a higher modality, more pricey, but it still can be a non-invasive tool that can be used and identify those patients, as long as the FFR is less than more than 0.8. It is still safe, but less than 0.8 or less than or equal to 0.8, this would be a moderate to severe ischemia. And at this point, we have to identify, send the patient immediately for invasive coronary angiogram. In patients with if any of those, like when we do the still the other arm, if we don't have the CCTA, so we still can do the stress testings. There's echocardiograms, there's SPECT, CMR, which is the cardiac MRI, or SPECT. So those are things, and we, to a lower extent, the exercise ECG, because the exercise ECG in high-risk patients is not conclusive, or sometimes it can it doesn't identify those patients, especially patients with multi-vessel disease. Sometimes they have the what's called balancing perfusion that makes things look as if it's negative, but it needs more accurate testing, and the other tests are more accurate than the simple ECG, exercise ECG. If non conclusive, we can do the CCTA or coronary angiogram. If mild ischemia, definitely we have to identify those patients, send them for CAC, the calcium score, or to optimize preventive therapy, so we can start the like anti-ischemic medication with them. Also, moderate severe ischemia, definitely we have to start the medical therapy first, and then we, if the symptoms are persistent, we if no symptoms, so they continue on the preventive therapy. If yes, we send them for coronary angiogram. In patient with stable chest pain or stable angina, for the if we identify for patient with obstructive coronary artery disease or stable chest pain, it's recommended to optimize the guideline directed medical treatment. And for patients with unknown or non-obstructive coronary artery disease, we still optimize the preventative therapy. So it's also like, yeah, we'll be talking about this over and over, as we mentioned, according to the previous algorithm. Here in this algorithm, this is still like, yeah, to identify the non-obstructive from obstructive. Non-obstructive means less than 50% stenosis. Obstructive means more than 50% stenosis. So in both arms, we have to identify those patients and start the guideline-directed medical treatment immediately, and then watch and see if the patient still having persistent symptoms. So we need to send him immediately, like, yeah, I'll not say immediately, but as soon as possible to do an invasive coronary angiogram. And if the symptoms are not persistent, so we can send them for stress testing and stress MRI to identify the functional capacity of the myocardium, and also to identify the burden of the ischemia. So if no ischemia or mild ischemia or moderate to severe ischemia, this will be like, yeah, need to be identified. And moderate to severe ischemia, still we need to do angiogram. So to sum up, we have 10 take-home messages, like, yeah, out of the 2021 guidelines. The first thing is chest pain means more than chest pain, and we have to be very meticulous about identifying those patients. As I mentioned, most of the chest pains are benign, but who is benign? This is our job, to identify and confirm who's benign from, or who's cardiac from non-cardiac. So any pain with pressure, tightness, discomfort going to the shoulder, arms, neck, back, upper abdomen, or jaw, especially jaw, this should be considered as angina equivalent, especially though, and also the shortness of breath and fatigue, especially in females. So those are symptoms that we have to consider as risky symptoms that should be identified. Again, high sensitivity troponin test is the most preferable cardiac enzyme that can rule in, rule out those patients. Can identify like acute coronary syndrome patients like in less time. We don't like keep patients like in the emergency department for like 12 hours and 24 hours to find out. Like high sensitivity troponin test can be done and can give us like, yeah, accurate results within like 2 to 4 hours maximum. So at this point we can triage those patients, and some of them can be sent home if they have low risk features, no ECG changes, and negative repeated troponin test. Early care for symptoms, definitely patients with acute chest pain or chest pain equivalent symptoms should seek medical care immediately. And this is definitely according to the guidelines, like, yeah, the 911 is the universal for them, or the national number for them. Here, I do think that is 119. I do think, but still, here is not so valid because I didn't see like many patients like using this and it activate like STEMI call or anything. So still, the patients, they know the hospital, they go directly to the hospital. So definitely, I recommend like all patients to have the numbers of hospitals, especially heart hospitals, because this will reduce the time of wait and also the identification, so we can proceed immediately in treating those patients and saving their lives. Sharing the decision-making. Clinically stable patient presenting with chest pain should be included in decision-making. Information about risk adverse events, radiation exposure, and all those things if we use the invasive maneuvers. Also, I would like to say something extra, that sharing decision-making between colleagues, physicians. So sometimes we need to know like each other much better, because like, yeah, if I'm a physician that is in the emergency department, or a GP who has a patient like having acute chest pain, I need to have an access to a cardiologist or an invasive interventional cardiologist, so I can send the patient immediately, don't delay the decision making, and I'm like, as I'm saying, to proceed to treatment as we mentioned in the guidelines. As I'm saying, we have to identify low-risk patients, so we don't like waste time doing a lot of testing, that the test probability will be very low. So but still we need to identify those patients first. Clinical decision pathways for chest pain in the emergency, we have to understand because sometimes when we look at the algorithm, we think that this can take time, but actually this is in a matter of minutes or like half an hour. You can finish the triaging of patient, put them like, yeah, this is cardiac or possible cardiac or non-cardiac chest pain. So you can proceed according to every category. The common symptoms, like chest pain, is the dominant and most frequent symptom for both men and women, ultimately diagnosed with acute coronary syndrome. But women, as we mentioned before, may be more likely to present with a common symptom such as nausea or soreness. So patients are also most likely to benefit from further testing. Patients with acute or stable chest pain who are intermediate risk or intermediate to high risk, pretest risk of obstructive coronary artery disease, will benefit the most from cardiac imaging and testing. Non-cardiac is in, as we can say, atypical is out. We don't identify chest pain as atypical anymore. It should be like non-cardiac, possible cardiac, or cardiac. Structured risk assessment should be used for patients presenting with acute or stable chest pain. Risk for coronary artery disease and adverse events should be estimated using evidence-based diagnostic protocols. And this is like, as we mentioned, we have to look. They mentioned a lot of tests that can be done, but actually the algorithm can be according to what is available. So if you have a facility that can provide the simple ECG and then stress ECG or stress echocardiogram, SPECT, or the nuclear test, CT scan, or up to invasive like coronary angiogram, definitely you have to make use like a good use of those resources. So we still, whatever we have in hand, we have to use and definitely benefit, like, yeah, to the patient and to the physician in the process of decision making. And thank you.
Thank you, Dr. Suleiman, for the wonderful presentation. And I think you cover most of the ground. So it's time for comments and questions from the participants. If you still have any clarification to be made concerning how to approach patients with chest pain, whether the acute chest pain or patient presenting with chronic chest pain. So the floor is open for comments and questions. So it seems Dr. Suleiman has done a very good job.
Okay, so let me open the floor since no one else wants to say anything.
Okay, sir.
Dr. Solomon, thank you for a very good tour of um, acute coronary syndrome and angina. I want you to speak for specifically to how acute coronary syndrome should be addressed in Jamaica in the context of probable acute myocardial infarction or unstable angina. Speak about the speed and the efficiency of care and what the data shows about time to intervention.
I've mentioned the time to intervention in those patients with acute coronary syndrome. Acute coronary syndrome is identified in 3 categories. One is the STEMI, the other one is non-STEMI, and the last one is the unstable angina. So the timing for STEMI, it is matter of like between minutes and hours, especially once the patient reached to a hospital with cath lab facility there. So it should be like, yeah, the door to balloon time, as we can say, should be between like 60 and 90 minutes maximum. This is and this is universal timing. So, but the problem is before the door time, which is the identification of those patients by their physician, or even the patient themselves are well educated to understand that this might be like a heart attack because of the symptoms, so they can go to the right place, the right time, and then can be identified by the other physician, like at the ER and so on. The non-STEMI, as we mentioned, the high risk is immediate intervention. Okay, but the immediate intervention is within like 2 hours of presentation to the hospital. The very high risk patients, high risk, and still like needs like intervention within 24 to 48 hours maximum. They omit the intermediate risk in the last guidelines. I do think of the European guidelines, and they said that there's the low risk patients, they still need some further testing. So we have like low risk patients and the high risk and very high risk patients. Those are the but still those need to be identified through their through the interventional cardiologist or the cardiologist they see. For unstable angina, this is like, this is according to the frequency of the symptoms, especially a patient who's known to have like stable angina from before, and then start to have like change in the character, or the first time to have chest pain. This is also identified as unstable angina. Still need to go immediately to any hospital or cardiac hospital, being identified by the physician, and do the ECG, the cardiac enzymes, and so on. If both ECG and cardiac enzymes don't show any sign of acute ischemia or something, we still need further testing, and intervention will be identified according to the risk class of the patient. So the data still showing like, the very high mortality rate, like with the STEMI patients, especially when I read some papers about like even like rural areas that they don't have intervention facilities over there and so on, and how the risk of morbidity and mortality over there is way higher than being in a city or being in a place that is nearby a hospital that can deal with acute coronary syndrome patients and so on. Still, we need to deal with that. We can have some raw data from our hospital with those patients, like, who are known to have myocardial infarction somewhere in the rural areas in Jamaica, and then they are sent ratherly very late, because like they can be sent like after a week or 2 weeks from the acute event, as a regular referral to see a cardiologist, which is like at this point, sometimes most of the patients have lost significant portion of their myocardium, and the treatment options become a little bit limited. Still, they need to be identified anatomically because sometimes, yes, the patient has STEMI in the anterior and is missed, but still have some viable myocardium. This needs some further testing by the vitamin stress echo or something, viability study. Or sometimes they have multi-vessel disease, so we have to identify also the other areas of that can be jeopardized in the myocardium. So based on that, it is first patient education. Like, yeah, patient needs to understand what's his chest pain, because as I'm saying, the patient himself sometimes is confused and says this stomach pain or gas pain or something. The second, the GP himself should be educated about any chest pain is emergency. And I appreciate your effort, Dr. Madhu, in identifying this in many conferences and also in the newspapers and so on, that this should not be taken lightly. Yes, chest pain, as I mentioned in the presentation, can be non-cardiac, but if it's cardiac, it's time wasted. Like when we keep sending the patient to do this and that, and we don't send them to the specialist directly and immediately or on the same day to be identified, is it a cardiac pain or not? So our colleagues, GPs, and our young fellows, like in the hospital, especially in emergency departments, they need to gain more knowledge and also to react differently to those patients with chest pain. Okay, this is not about like giving them some painkillers and they will be fine. No, they need to be triaged and identified meticulously. ECG should be done immediately for any patient presenting with chest pain without any delay, because at this point, many patients that you think that is not non-cardiac will be turning into a cardiac patient that needs immediate attention, especially in a STEMI patient. So I know we have some struggles in this process, because some physicians also, they think about the financial status of the patient, which is something that we should not be looking at. We have to mention, we have to recommend, we have to push patients to take the right decision. This is our rule. If the patient can do it, it's okay. If the patient cannot do it, there's many ways that we can still assist those patients to get the right right treatment. But not to mention to the patient that he needs to be transferred immediately to a hospital or something. This is, I do think sometimes it can be a crime.
Thank you very much. Just to piggyback on that, I wanted to, I don't know if it's a comment or a question, but I agree with you completely. I think we've, over the years, we've been trying to sound the alarm that every chest pain is an emergency until proven otherwise. There are people who have a vested interest in making patients, ignore chest pain, because, of course, it will probably cost the third party payer money to take care of it, but that is putting patients' lives at risk. So we encourage all our colleagues, doctors, to do the right thing and encourage patients with chest pain to treat it as an emergency, because time is muscle, as we say, and delay could be catastrophic, for families and to individual patients. Last question to you, Ahmed. Is there any circumstance ever that you will refuse to take somebody to the cath lab who has ST segment elevation, myocardial infarction with recurring and ongoing chest pain, just because their initial chest pain was more than 48 hours ago?
No, the chest pain is a chest pain. This is a symptom, and also that was identified by ischemia trial that those patients still like having the benefit as regard to mortality and morbidity if we can identify those patients and we go for early invasive strategy. So any patient with chest pain, even after myocardial infarction, should be treated as we can say like risky PCI or something. We have different like identification of those different definitions of what kind of PCI it would be, because patients after myocardial infarction, still post myocardial infarction ischemia and angina, this still needs like early invasive maneuver. But definitely sometimes it can be a complication related to the myocardial infarction, and that's why they still have persistent chest pain after that. So yeah, we saw it. It's not so common, but we saw it like acute VSD or acute mitral regurgitation or something that presented a little bit late. Sometimes that pain is post-infarction angina. I'm sorry, post-infarction myocarditis or pericarditis. Those are things that can happen from time to time, but after the only thing that we have after myocardial infarction by like so many hours is the time. We can take some time in doing some further non-invasive investigations first before we go to the cath lab, because we can predict that this patient may have higher possibility of having complications. But this will never delay the invasive coronary angiogram in those patients.
All right.
Thank you very much, Dr. Suleiman. And one addition that I will have is an approach that I was trying to do in a similar environment like America to try and at least for patients that have been treated multiple times for so-called gas pain and what, try do an ECG, please. Try do an ECG, and doing that, we were able to see more than 50% of patients with ST segment elevated myocardial infarction, and most of them coming in very late. So I think one of the take-home points is not all gas pain are gas pain. Check ECG and examine the patient very well. So thank you, Dr. Suleiman, for the wonderful presentation. And I want to appreciate everybody for staying with us till this time. So next week, Thursday, we do another time for another cardiology topic, and that will be circulated early next week. And you should send in our email so that you can get your CMA sent to your email. Thank you very much for your time. So we'll see you next week. Bye-bye.
Okay. Thank you
Thank
all.
you.
Thank you. Yeah. Bye.